Hello everyone, welcome to my presentation. Our topic is all about chest X-ray, PA projection. So first, what is projection? The term projection is defined as the path of the central ray as it exits the X-ray tube and goes through the patient to the IR or image receptor. Most projections are defined by the entrance and exit points in the body and are based on the anatomic position. So our topic is PA projection, posterior-anterior. A perpendicular central ray is shown entering the posterior body surface and exiting the anterior body surface. The anterior aspect of the chest is closest to the image receptors, or was the X-ray taken from back to front. We are using 35 by 43 centimeter lengthwise or crosswise image receptors for the hypersthenic patient or depending on the size of the patient. Orientation of the larger cassette will depend on the width of the thorax. SID means source to image receptor distance. Distance from the anode inside the X-ray tube to the IR or image receptors. Okay, SID is distance from the anode of the X-ray tube inside from the image receptors. A minimum SID of 72 inches or 183 centimeter is recommended to decrease magnification of the heart and increase recorded detail of the thoracic structures. Now we are here in position of patient and image receptors. Erect, chin raise, hands on the hips, with palms out, roll shoulders forward. Center CR to T7 region. Top of IR will be approximately 2 inches or 5 centimeter above shoulders on average patient. Okay, top of IR will be approximately 2 inches or 5 centimeter above the shoulders. This one, 5 centimeter. Center thorax bilaterally to IR borders with equal margins on both sides ensures there is no rotation of thorax. If possible, always examine patient in the upright position, either standing or seated, so that the diaphragm is at its lowest position and air or fluid levels are seen. Engorgement of the pulmonary vessels is also avoided. Place the patient with arms hanging at sides before a vertical grid device. Center the mid-sagittal plane of the patient body to midline of the IR. Have the patient stand straight with the weight of the body equally distributed on the feet. Extend the patient chin upward or over the top of the grid device and adjust the head so that the mid-sagittal plane is vertical. Ask the patient to flex the arms to rest the backs of the hands low on the hips, below the level of costophrenic angles. This maneuver rotates the scapulae laterally so that they are not superimposed over the lungs. Depress the shoulders and adjust to lie in the same transverse plane. Rotate them forward to position them below the lung apices. If an immobilization band is used, be careful not to rotate the body when applying the band. The least amount of rotation will result in considerable distortion of the heart shadow. If a female patient breasts are large enough to be superimposed over the lower part of the lung fields, ask the patient to pull the breast upward and laterally. Have the patient hold the breast in place by leaning against the IR holder. Central ray. CR perpendicular to T7 or 7 to 8 inches, 18 to 20 centimeter below vertebra prominence, is also near level of inferior angle of scapula. Okay, this is the scapula, so the inferior angle of the scapula near level. Central ray. Again, SID. 72 to 120 inches or 183 to 307 centimeter. Collimation. Upper border to vertebra prominence, sides to a lateral skin borders. The collimated horizontal beam is directed at the right angles to the receptors and centered at the level of the eight thoracic vertebrae or spinous process of T7, which is coincided with the lung midpoint. Respiration. Expose at end of second deep inspiration. The exposure is made after the second full inspiration to ensure maximum expansion of the lungs. The lungs will expand transversely, anteroposteriorly, anteroposteriorly and vertically, with vertical being the greatest dimension. For certain conditions such as pneumothorax and the presence of the foreign body, radiographs are sometimes made at the end of full inspiration and expiration. Okay, now we are here in PA radiographs of the lungs. A is for trachea, B and C is for right and left main bronchus, E is for pulmonaris arteries, D is for horizontal fissures, G is for diaphragm. The following should be clearly demonstrated. Entire lung fields from the apices to the costophrenic angles. No rotation is external ends of the clavicle equidistant from the vertebral column. Trachea visible in the midline. Scapulae projected outside the lung fields. 10 posterior ribs visible above the diaphragm. Sharp outlines of the heart and diaphragm. Faint shadow of the ribs and superior thoracic vertebrae visible through the heart shadow. Lung, lung markings visible from the hilum to the periphery of the lung. With inspiration and expiration chest images, diaphragm demonstrated on expiration at the higher level, so that at the least one fewer rib is seen within the lung field. Note: inferior lobes of the both lungs should be carefully checked for adequate penetration on women with large pendulous breasts. Okay, that's all for today. I hope you gained some knowledge in this video. Hope you like it. Please like and subscribe for more updates and topics. Thank you for watching.